Welcome to the Integration Station. I'm Michael, child and adolescent occupational therapist, and with me today for this special episode is Eleanor.
I'm also a child and adolescent occupational therapist.
So today's episode is a bit different. We had one of the most renowned sources in Ayres-centric integration. She was actually a student of Dr. Jean Ayres, the founder of Ayres-centric integration, and that was Susanne Smith Roley. She spent some time with us in our clinics, and we were extremely fortunate to have a superstar in our space. And she gave us some of her own time. We had sort of a Q&A session a few weeks ago. And this episode is some of the best bits from that, and hopefully something that all listeners can take from. But I know there was some points that you took from it, Eleanor, that you really liked, that you wanted to quickly share for our listeners.
Yeah, absolutely. And I don't want to give away any spoilers,
Too much, sure.
But I really did love actually hearing her talk about the application of Ayres-sensory integration and the evaluation in Ayres-sensory integration, the EASI assessment in the adult space. Because I know that's something that we've been exploring a little bit more with some of the, young adults or even parents, adults that are accessing the space, to see how we can best utilize that with them. So I loved hearing her take on that.
Yeah. One thing I loved was when she was talking about, you got to love what you do.
Yeah.
And if you're an Ayres-centric integration therapist, you'll know that that's the right thing for you, because if you love it, you won't want to stop doing it. And that just resonated for me. I think her time here reinforced why I do what I do. Sometimes you need that.
Yeah, absolutely.
You just need that affirmation that, this is the right place for me, and ASI is the right therapy for me. So,
and she is just a wealth of knowledge, and was
and so
able
chilled,
to respond.
So Southern California.
Yeah, she's
loved
so
her.
great.
So hopefully you enjoy listening to what Susanne has to offer, and we'll see you all next time.
Thanks, everyone.
Well, first of all, thank you for inviting me, and then I'm so impressed there's so many of you. I sort of had a smaller image of a smaller group in mind, but this is awesome. And so I think it's really nicer if it's a conversation. I don't want to lecture. And you guys had some amazing questions. And so what I was able to do is kind of categorize them, because that's going to help me. And a while back, the research collaborative that I'm in, that includes Roseanne Schaaf and Zoe and Anita and a bunch of amazing people, we wrote an article called The Pillars of Research. And there were essentially, it was sort of subsections of research. It was in the article, but I think that there's actually 4 pillars of our practice as occupational therapists: education, practice, research, and advocacy. And you guys had questions that kind of spanned each of those topics. So I put them in that order. All right. So first of all, education. One of the questions was, are there recent studies, key research textbooks you would recommend for someone exploring ASI with autism? Oh, I would have to say that there is just a magnificent number of things. Of course, I published an article that was characterizing the sample of autism and sensory integration concerns. And this was in 2015, and of course, I highly recommend that article. More recently, Schaaf and Mayu published an article on the sensory phenotypes of autism. It was a bit of a sequel to my article, and they did it slightly differently, but that it was really, really well done. And they had, a large sample characterizing the sensory features of autism. And so that, that's really good. And then of course we have all of our evidence. And so the evidence in autism, and we have evidence briefs in CLASI, which I think you can access online, which will be updated. And then there's a textbook. Heather Miller-Kohanek wrote a textbook on autism, first and second edition. It was taken over by Watling et al. And that's a book. That's got a lot of, it's not specific to SI, but we have a chapter in there that I think is, pretty nice. So I don't know. I think there's volumes being written on autism and ASI. It just depends on what you're looking for. But I think if you're looking to get the basics on SI and autism, my first stop is sensory integration in the child. Okay, and then the second stop might be, some of these articles on the phenotype. I think my article and the Schaff et al. Article, I think it really talks about the sensory features that we find in autism, and it's the findings are quite consistent.
What was the research like? What did that entail for you? Was that research looking at what had been researched, lit review, like where was...
Well, we did a quantitative design, which was a characterization of a sample of children with autism, ages 4 through 12. We ended up with 89 in the sample, and I published it for my doctoral work. And because I'm just crazy enough to test everybody that walks in the door with the SIPT and the SPM and everything, or at least try, we looked at maybe over 400 files, and we pulled the ones on autism. And so, of course, we had more than that, but I knew, because I tried to test everybody with a SIPT, how many could not take it versus who could take it, which I thought was very valuable. And it was just like, I think 51% of the kids with autism were able to take more than 11 of the subtests, or the individual SIP tests. I thought that was remarkable, because there is some rhetoric out there, you can't test kids with autism with this stuff. And you absolutely can. And then I also gave the SPM, I also gave the FLIC. We did all of those analyses. We showed what the patterns were, so strengths in visual praxis, significantly poor in every other way. Somatopraxis, visual praxis was good, somatopraxis was poor with vestibular, language, all of that. So, and then we did correlations with the SPM, and we found that the surprising finding was the highest correlation was between the praxis tests and social participation. And I honestly thought it would be reactivity, right? Because I always think of that related, and of course that correlated, but praxis showed a phenomenal correlation, and that really has changed my thinking ever since then about what you need to interact socially, particularly with unfamiliar people and with peers. I didn't publish on the FLIC, but we have FLIC data, and it's the Family Life Impact Questionnaire, which we use. Yeah. So it's meant to be an occupational profile, and so what we hope to do is correlations with all of the normative data we have on the FLIC with the EASI. We'll see when we get time to do that. But what was really apparent is that in the kids with autism, always or often they seem to relate well to familiar caregivers, and rarely or never did they relate well to peers and unfamiliar people. And I think, okay, well, that takes praxis. Anyway, so that we were able to publish that. We could show that there's not simply the reactivity pattern, but these other perceptual, motor, and praxis concerns that seem to somehow get lost in the focus on reactivity in autism. And certainly that's a big concern, but there's this whole other big, I published that in 2015, but now there's much more written on dyspraxia and autism. At the time, there was very little. It wasn't even acknowledged. There was a time when people didn't even think motor skills were problematic in autism because they could run really fast away from wherever you were. But now they know that's not real. And then the Schaff and Mayu study, and I think that was like 2022, was very similar. Okay, so what I'm saying is, those two might be a way to start, just to understand what the sensory characteristics are. And then we have all of these randomized clinical trials, that are showing the effectiveness and what could change in participation studies. So I shared a reference list with Dino. You can have it. There's one on the CLASI website. Yeah, and so then I would start looking at those. Yeah. and then dive deeper. Yeah. All right. Then in terms of assessment, one of the questions was, can the EASI be used on adults? And absolutely. Now, you guys, those of you who have learned the EASI, did you find one or more of the tests maybe challenging for your very own self? Okay. So yeah, I think we firmly believe that the process of learning the EASI helps you to have that embodied knowledge of what the constructs entail, because they're hard, and they're hard to learn, and so absolutely. So I have always used the SIPT on adolescents and adults if they seem to need it. These, and actually the EASI is coming out similarly, that, there's a developmental curve on most things. Of course, not all, like nystagmus is pretty flat across childhood, but it flattens out around 9 or 10. Okay, so they do, 3 to 9, 10, and then it starts to flatten out 9, 10, 11, 12. They're not that much better. In fact, we will find out, but we might be able to collapse the age groups in those older ages. But what that means is these are developmental sensory motor abilities that should be intact by about age 9. So your 12-year-olds don't do that much better than a 9-year-old standing on one foot in your typical population. So when you're testing, say, a 14-year-old, and you're comparing them on the EASI to a 12-year-old, you don't know if they're as good as other 14-year-olds, right? You don't have that normative comparison in the high ranges. So if they have good scores, are they really as good as a 14-year-old? You don't know. But I don't mess with that, okay? Because I don't know that. All right, so they got a good score, it's a good score. Okay, but if they have a bad score, they're being compared to children who are younger than they are. So they're 14-year-old being compared to the 12-year-old, they're still scoring at -1, -2, -3. That shows significant challenges in that area. And I make no apologies about that. I mean, I test a lot of kids, my evaluations often go to court, I'm often challenged on that point, and I'll say, yeah, well, they should have had it by 9, they don't have it, so what are you going to do, just not test it? Is that the solution? And why would you create tests for things that are not relevant in that age group? And so that's the other dilemma about developmental tests, is it doesn't make a lot of sense for us to create a whole new test for adults on things that they should have intact by childhood, right? So you're in the typical sample, they're all going to do great. So that's sort of a test and measurements dilemma. But what we should do, and this is Anita Bundy, she goes, well, you should collect the data on the population for which you're going to use the tests. I'm like, okay, so we really just should start testing adolescents and adults with the EASI and collecting that data, and then we can analyze that data. And I think that that's really what we ought to be doing. I still can't do the sequences test. Yeah. And I created some of those items, and but that was hard for me as a child, and it's hard for me now. And so you can see the vulnerabilities that you have as adults. And I mean, would I score in the atypical range? Probably not. But when you have the kind of clients that we have with challenges, they're going to show up. And I think they need to be documented. And I love that I can get a graph that shows on a bell curve where that, like the level of severity of the perceptual motor challenges. All right, I love this question. Since I've been practicing, he said 14, I'm saying 40. and that's generous because it's almost 50. What do you put in place to be a sustainable practitioner? I put it first because I think this is the most important question you guys all have to consider for your career. And do you love what you're doing? And if you don't love what you're doing, you're not gonna last 40 years, And if you don't like the kids, or if you have a caseload, if you don't have supervision, but you guys are in a magnificent world-class facility that is, beyond expectations, with amazing mentors. But even so, some days are hard. some days are hard, and you got some clients that are maybe don't change enough that feels so rewarding that you're seeing those changes on a day-to-day basis. All of that's really real, and you want to stay stimulated. And so, my first suggestion is that you take care of your health, and that's no joke. Because we've got younger therapists, they hurt their back, they hurt their wrists, then they can't, they let a kid fall on them wrong, and then everything hurts for a long time, so you've got to learn your safety stuff and your biomechanics and all of that, and how to manage the kids so they're not falling on you, and you have all your safety equipment and stuff like that. And then the cognitive piece is important, right? That you feel like you've got a good working relationship with your colleagues, and then you keep each other interested and excited about stuff. And I think that's the thing that we really did is, have study groups, bring, we had our, I don't know what we called it, but it was like a wine and cheese night, monthly, of course, and everybody would come and they'd bring their cases, and we'd just talk about cases, but in a less formal atmosphere, because we're always running and don't really have a lot of time, and so you have these, clinical questions, and I think those sorts of get-togethers are really, you have support, and also that you don't feel like, am I just being stupid? Am I just not making anything? Where you start feeling like everybody's doing a great job but me. Don't do that. Don't do that. Just get together with your colleagues. And then I think one of the things that has sustained me is that the work in sensory integration is so, in my mind, so dynamic, so phenomenal, so many ways that you can continue to do growth and development in those ways, getting involved in state and national associations, international associations, all of that. And then, have some really, really smart friends, really, really, that say, come on, let's write a paper. It's like, I don't have time to write a paper. Yeah, come on. And it's like, all right. Yeah, so keeping a little diversified in your practice so that burnout doesn't happen too quickly, and take breaks and, make sure you come refreshed. I don't know. Well, and I know with CLASI, we're really focused on building community, and Dawar, I just absolutely love him and have for forever. And we have this international community that we stay together and we have fun together, and we try to go where each other is, and these international congress, and we don't get to see each other all the time, but if you feel part of a community, and a community that's growing relative to your own individual value system, that it's something that you enjoy and that you feel good about, I think stay involved in that community, because we're trying to build an international community of practice, and you guys have an amazing start, because look at all of you guys here. All right, now this one, okay, you're not going to like my answer. How do you ensure a session is child-led rather than child-controlled? I'm going to tell you, let them have it. let them control it. And then you have to be smarter than they are. Okay, and that's hard to do. But I 100% believe in a sense of agency, that your client has a sense of agency, which means that they have self-determination, and that one of the ways that we empower our clients is for them to be able to make decisions. They're not always decisions we want them to make. Now that's your job as an adult, okay? And they're never mistaken about who's in charge, I mean, I might get on the floor and play with them, but they know that I'm going to tell them no if they, and I don't care how involved they are. They know who's alpha in the room. But I can give a lot of leeway, and then I have to figure out what their nervous system is really telling me, and then try to make it adaptive. Okay, but from a sensory integrated point of view, the master clinicians you see treating, they will ask, they won't tell. they'll follow instead of lead, and then they build around the interests and the abilities of clients. It's really harder than it sounds, but I also feel like it's the most rewarding. Okay, so we do have some pretty bossy little people that we work with, but if you think about it like a 2-year-old, like how great is that if that's really going to lead to their own ability to self-advocate, to have self-determination, and these are really important values. So child-controlled rather than child-led, same. But your job is not to let those decisions go into the maladaptive realm, that they're going to hurt somebody. I tell the parents and the kids, I only have 3 rules. You can't hurt me, you can't hurt yourself, and you can't hurt my stuff. Okay, so nobody's getting hurt in here, all right? So that, that's an absolute no-go. But outside of that, you want that instead of this? You want to go there instead of here? You want 1 time instead of 5 times? No? All right, you got it. What else can we do? Where else could we go? Yeah, so it's a lot of inquiry. Okay, what else? And then that is also the gateway into working on praxis. And praxis, that word means, to do. But it's planning. It's planning what to do. So how are they figuring out what to do next and next and next and next? So planning and organizing. And you guys, everybody I saw in every setting today, and I know we were like little peeping toms, but all of you have very good praxis. And it's really hard to deal with all of these like really abstract kind of materials and everything if you don't have good praxis. And so sometimes you have to let go of that and have a little wander, because the kids are not going to have great praxis, and let them try and maybe not get it quite right, and then and it's a little trial and error. But that's how they build their praxis. Then they get to start to like decide and go where and what and how many and all of that.
Then can I ask, so let's say in a space like this, like a client might gravitate towards the basketball court, and you're like, that's fine, I'll let them do that, good rapport. It's like the first few sessions you're playing basketball, and then you're going, okay, and perhaps it's a client too that demand avoidance is really strong. So how do you manage that when you want to incorporate their interests, but obviously you've got goals that you're potentially looking to work towards? What's the balance for you?
I would be building, I'd be stacking stuff underneath the basketball court. I'd be hanging something off the hoop. I'd be tying ropes to the trampoline. I'd start building around that. I'd try to create something else that looked like a basketball hoop to try to get them to expand out of there. And I mean, if it's every single time, like, can they get a basketball hoop at home? And, then it's not such a... Yeah, so try to move them from their comfort zone, because I think that's where they feel safe and interested, into like taking some risks, if you can somehow hang up a wastebasket or something, I don't know, to cut a hole in it. I don't know. Try to, so we try to move it away from there. But I know sometimes that gets hard. Or sort of, depends on how much language, or you could start to ask them to try something new, like, okay, can we have 10 minutes and we do something else, and then we'll come back to this, and then you start negotiating, like, okay, what else? Okay, my turn, your turn. It's a collaboration. Yeah, I mean, kids don't have 100% control of it. We collaborate on that, so, and I think modeling turn taking, and can I have a turn, and, can you have a turn? No, I can't have a turn. How come I can't have a turn? That makes me sad when I can't have a turn, so then you go into that social skills narrative, but, how much do they understand that? It depends on the client, but yeah, I mean, it isn't just do whatever they want. That's not, then that's not therapy. So client-led is really not so much about obsessive interest as it is what their nervous system is telling you. So are they doing that because of a heightened level of arousal, and they just need the comfort of familiarity? They're so dyspraxic, they don't know what to do, and everything else is very scary, or just they don't know how to do it. And so then, that's your job to expand around that. Yeah. And then, the next two were like what to do at home, and parents, how do you explain the things to the families, and what about parents that just don't get it? And if they don't get it, it's going to be really hard for you to transfer what you're doing into home. So I see those two things as a little bit connected. But yeah, so we try to engage the kids in activities that are portable. Sometimes these things, so maybe you're doing this stuff, they don't have any of these kind of equipment at home, but what could they have? Could they have a chin-up bar in the doorway? And so, could they get a swing in the backyard, or could they have a tactile bin that they could play with, or there's a game that you might be doing with them with the turn taking and things, and could they do that at home with their family? And so any of those ideas that are portable, we try to get them to do, but it kind of all does hinge on that reframing a lot of times and understanding. So as you get the test results, you're reframing in this sensory motor language of why the child might be doing something. And so they might already have an opinion on why, and then grandma thinks that's why, and dad thinks that's why, and mom thinks that's why, and then the teacher thinks that's why, and then you're going, well, I think it's sensory, or praxis, or there's motor concerns or anxiety or something. And so I think that's a dialogue, that's an ongoing conversation. And sometimes families are not able to digest all of it at once. And I think that can be very overwhelming. I know our reports, parents will say, I have no idea what any of this means, Okay, so what are you going to do? Like, how are you going to meet those goals? So the piece that starts with what's keeping the parent up at night, that's the place to begin. It's not all of the things, but what is the thing where they're losing sleep? Like, it's not going to be something like prone extension. It's because maybe they're getting bullied, or maybe it's because they're crying a lot at school, or they're begging not to go to school, or they don't have any friends. And okay, so what is that piece that's really tearing up the parents? And that's where I'm going to start. I'm going to start there. Like, okay, let's solve this problem. And here's what I have that relates to that concern, and let's tackle that first. Okay, and there's more that we can do, but we can, let's get to that. Let's talk about that next week. Let's see what we can do here the next month. We're going to work on this for a while. And so I think if you break it up into and the families are very appreciative if you can start to give that understanding. There's not always a mutual understanding between all of the family members, though, right? So you might have one parent who's just gung-ho, and I really get it, and I really want you to see, and the other parent that thinks that, no, but it's your fault, and you're not parenting well, and we don't really need this, and I was just like that when I was a kid, and I turned out just fine, and so, and then you've got to navigate that as well, where people think you're just a charlotte and you're just taking their money and whatever. It's like, okay, fine. But, sometimes those people who say, well, I was just like that when I was a kid, and I turned out, and I'm an attorney, and I'm just fine. Like, yeah, well, wasn't it hard for you when you were a kid? Wouldn't you like to make it easier for your kid now that there are these, we have this intervention that might not have been available to you, but your child has this, and life could be easier. I'm like, well, so sometimes they go, yeah, I would like it to be easier. I think our communication skills with all of the people linked to the client, starting with the client, I think we do a really good job, even with those kids that are nonverbal or whatever. I think we do a really, really good job, and we have to do equally good job with the funding agency, with the granny, with the teacher, and I think that's a whole skill set of maturity where you have the confidence in your data and your methods that you can stay strong in your conviction despite somebody being very skeptical. But you damn well better have your stuff in order. Okay, don't go launching into a lot of self-confidence with nonsense. Don't do that. Don't do that. There's a cadre of people, and I don't know where they're getting it in the US, that says that if your child has ADD and they have problems on the SPM, that's normal for ADD, and so that's just normal. Or if they have problems on the SPM because they have ASD, there's a chart that shows problems with ASD and the SPM, so that's just, that you just expect that. So no OT is necessary. And I'm like, that's ridiculous. That's like saying I went to the doctor, my insulin levels are off, so you have diabetes. That's what you get. Yep, you got diabetes. Have a good life. No, no, you're finding symptomatology that is relevant. But just, yeah, I mean, because people have, I mean, sometimes go in with very strong opinions and they're dead wrong. And maybe it's contrary to your findings. Oh, it's a proprioceptive deficit. Yeah, but they got 2 good proprioception scores. Did you test proprioception? Oh, well, they scored, some problems on body awareness on the SPM. Like, no, no, you don't. You just have your research behind you. Make sure that you have, or you can find it. Like, or if you don't know the answer, let me get back to you on that. Let me find it, and I'll get back to you. Because then you can go with a lot of conviction. Like this is what the research is saying. All right, so some of you are aspiring to do research. Where do you start? Okay, well, first thing I think as clinicians, I think you guys already have the first step in place, because this clinic is remarkable in how systematic your documentation is for assessment and also for intervention. So that's the first piece. If you're very serious about research, I think the best thing is to enroll in a PhD program and learn how to do research. I mean, that's really ideal. We at CLASI are very grateful that Dina was able to contribute some of your data for our studies. And then if you guys want to participate in the analysis and the article writing and all of that, we are very happy to have people who really have extra time to come and do things. Sometimes it's doing the lit review, sometimes it's contributing to, the characteristics, writing about the method, probably the methods, not the methods, but, to contribute to some of the discussion, or, there's things to do in an article. And so if that was something you were really passionate about, to let us know, right? But you'd have to be very serious about it. The other pathway is to look at the CLASI website, and if you truly have a study in mind, there's an application for a mentorship on the CLASI website, and Roseanne's our our research director now. But we have a lot of bona fide studies, right, to wade through. Like people who actually may have grant funding, who have a mentor, who already have a statistician, like for reals. So if you're just getting your feet wet, I would say, make sure you have maybe a master's program, a mentor at a local university. Read the research, that's the other good place to start, to know the different methodologies and different types of research. But it doesn't mean that you can't collect clinical data and analyze your clinical data. But then, have a university partner, because it's one thing for a clinical practice to do program evaluation. In practice, that's why some of our stuff didn't get published early, because we didn't have an IRB, an internal review board that allows you to analyze data for public consumption, or for, to generalize to the public. I mean, so the IRB is essential. Now, a lot of times if you're doing like file drawer studies, like all of the data you have collected, you don't really need it'll probably be an exempt study, but you still have to get that exemption from an IRB. And so, so there's steps that you have to go through, but certainly if you, faculty at all of the universities are publish or perish. And so one of the hardest things they have to do is to find client data. And you've got a treasure trove here. So if you could collaborate with the university, then they can get an IRB through and all of that kind of stuff. Our main collaborator now is Thomas Jefferson University, because Rose there, she's going to be retiring. In the past, it was USC, because I was on staff at USC for 15 years. So we were, we could get the IRB. Diane Parham was at University of New Mexico. So yeah, I mean, usually it was, and now we've got, Anita and Shelley are at Fort Collins, and so usually it's by the faculty person and then and we have other affiliates, but usually because there's a faculty person we're collaborating with. So if it's really an awesome study that that CLASI thinks we could do together, we could get the IRB. We could find somebody to get us through the IRB. You guys are pretty magical. You could create your own IRB. You could create your own internal review board. That's complicated, but you could do it. All right, now, I think this last discussion is complicated. So this one got me. Okay, this neurodivergent American OT, I did look it up, thinks ASI is not neuroconfirming, but this guy is, he's got his favorites listed. He's got done in there and all kinds of things. So that we are completely respectful of neurodivergence, and I think we always have. It wasn't always termed that, but there's like an activism brand of that sometimes in my mind goes a little bit too far. Sometimes I think they're using I'm okay, you're okay, and not that our clients are jerks or anything. No, but they need support. So sort of on the extreme end of I'm okay, you're okay, we're all okay, everybody's okay. Well, yeah, you're okay. Well, if you're so okay, you don't need OT. That's not real. That's not real, because there's a whole lot of our clients who are not coping without an enormous set of social supports. What does that mean? I mean, does that mean that we shouldn't say that they have dysfunction? Maybe. I don't mind not saying dysfunction, but certainly there are challenges. And I think if you don't acknowledge the challenge, then how do you know what to do? And so for me, it's like, all right, well, I can't go to the extreme of saying, well, we're all okay, and we're just on different planes of all okay. I'm 100% inclusion and all of that. But so some of the people who are in this community but are we neuro-affirming, I suppose? I mean, are we using that language? But I will tell you that we are changing our language, and we're taking out deficit, we're taking out dysfunction. In the new theory course, I had to go through everything. We changed all of that. We took that all out. We try to state everything in the positive as opposed to negative. It's not such a big shift, but even in the models, I know at the Congress, one of my things is to present a remake of a model that I presented it was in our book in 2000. But I think that sensory integration was one of the first really strength-based client-centered interventions in OT. Because I was taught as an OT to identify this dysfunction and remediate it, and you test it. You test it, it's broken, you fix it, you test it again. If it gets better, you did a good job. If it didn't, they're discharged. And that, that was not a great model. But we've moved away from that for a lot of years. And so, yeah, I think we've always been very client-centered, that collaborative model. We have a high level of client satisfaction in every study that's done on SI, whether they decide that we've made enough gains or not. Client satisfaction is always really, really high. And I think that matters. So I don't know who this guy is, but I don't agree. I do think that, we have to rethink our language. We have to affirm inclusion, whatever that means. I think, independence, interdependence, dependence, I think those are really important terms when we're working with clients, either with short-term or long-term needs. And I think that we as a community, OT community, I think out of every profession, I think we really support independence and interdependence as a means to independence, right? That you don't have to do stuff by yourself. You can have adaptive aids, you can have adaptive people to come in and support you, and you can be independent with supports, and that's not a bad thing, and we provide that. And so, I don't know. I don't want to get into the politics of it. And then why don't more people do pediatric SI? And I think that's a cultural question. I think we kind of know why. I think the leadership that has big influence at the academic level and other levels, if they like it, then it goes through, and if they don't like it, it doesn't go through. And I think there was a lot of that influence in all the Commonwealth countries of SI being kind of squashed. And then I think, first of all, but second of all, I think you have to have divergent thinking. So if you are a linear thinker, sensory integration is not going to work for you. And so it's a complex theory, and it's a complex intervention, and it's harder than some of the other things we do as OTs. And it's not so straightforward. And the outcome is not immediate, right? So the adaptive responses or the outcomes are not often within the moment, they're outside, and so people who are a little more concrete are not going to love this. But we've persisted, and it's all over the world. CLASI is now in 40 countries, and huge interest and need. And I'll tell you, if the OTs don't get on board to make it happen in Australia, somebody else will. So if we don't do a good job, and if we don't keep going, and if we don't keep making this feasible, acceptable, and replicable in terms of the evidence, somebody else is going to take it and run with it. So I think right now, all over the world, occupational therapy is the go-to profession for sensory integration, sensory processing. People don't know what OT is by and large, but they know sensory, you go to OT. But that means the OTs should do better. We should do a better job, and if we want to keep that reputation. And the last question, and I don't know if we're running out of time, what is the future of Ayres sensory integration? What does that look like? Okay, and I have the answer, but I'm going to give the talk at the Congress. The talk is back to the future, so that's my concluding remarks. All right, what do I really think? I just keep hearing Dr. Ayres quote, somebody was asking her this, and this was way back in the 1970s, and she said, I really think the future of sensory integration is going to be quite fruitful because of the advances in neuroscience. And she said, not just in this country, in the United States, but everywhere in the world. And I think that's true. I think that still is true. And I think, sadly, the number of human beings with sensory challenges is growing exponentially. Because now we don't just have the kids, we have the parents, and parents are identifying their sensory challenges. And now you see malls, and you see arts programs that are accommodating sensory, reactivity concerns, and so it's becoming more universally known, and because there's so many clients who need this work, I think it's just going to keep growing and growing. And you guys are the future of this. It's not me and the old guy over there. You guys are going to take it and run with it.
You said old guy, and then you looked at me.
Ah. Not that old guy. No, this guy's next generation, your next generation, and then you guys are next generation. You guys will take it and make it better. That's the plan. That's the plan. Because when we started, we didn't know. I didn't know what I was doing when I started studying with Ayres. Absolutely did not. Never did I think I would be in Australia, talking to you guys, when I was a young OT. I just thought this was a really cool thing that she was talking about, and I should figure it out. And I knew I didn't know enough to figure it out. And then it was like, well, then I should have a master's degree if I'm going to be teaching this stuff. And then I should, study neuroscience more. I should study statistics more. And I just kept doing that. If I'm really going to do it, I need to study this. I need to study. And I just kept doing it. And I should go study with her. And then I should have some really smart friends and do stuff with them. And here we are. But there you go. I mean, because you guys will do better than us. You have more tools. You have more... neuroscience is more advances, and the statistics are better. Everything's better, So, So I think that's what the future of SI is. I think you guys will make it what it is. So there you are.